further ado, I would like to introduce our first speaker, Dr. Maryellen Geiger. Her talk will be focused on data science and artificial intelligence in medical imaging of breast cancer and COVID-19. Dr. Geiger is an A.N. Pritzker Distinguished Service Professor of Radiology, Committee on Medical Physics, and the College at the University of Chicago. She worked for decades on machine learning and deep learning in medical imaging, being the co-founder of the first FDA-cleared machine learning system, currently called Clarity Imaging. She has extended her artificial intelligence research to include the analysis of COVID-19 data. Dr. Geiger is a former president of AAPM and SPIE, a member of the NIBIB Advisory Council of NIH, and the editor-in-chief of the Journal of Medical Imaging. She is a recipient of the AAPM William Coolidge Gold Medal and of the SPIE Directors Award, and is a fellow of many associations, including AAPM and SPIE. Dr. Geiger was named by the International Congress on Medical Physics and one of the 50 medical physicists with the most impact on the field in the last 50 years. Dr. Geiger was a chair for numerous AAPM task groups and member of several AAPM committees. Dr. Geiger, it is a pleasure to have you here with us today. Thank you. Dr. Geiger, please, if you can share your screen, will be great. We are a little bit early.
Okay. Okay, well, can everyone see my screen okay?
Yes.
Okay, thank you. And thank you for the invitation. I'm very happy to present to your chapter today on data science and AI in medical imaging of breast cancer and COVID-19. Let me start with my funding and conflicts of interest, as you can see here. These are the educational objectives of my talk. 1, appreciate the various data science components involved in the development and evaluation of AI for medical imaging. 2, appreciate the motivation and need for the establishment of an open and fair imaging data commons like MEDRIC, and understand the methods for creating, de-identifying, curating, and transferring image data from clinical sites to the public commons. And 3, obtain exposure to AI techniques across various clinical tasks in breast cancer and COVID-19. So first, let's think about what is AI. It's the theory and development of computer systems able to perform tasks that usually require intelligence, human intelligence. And so you can see it here is that AI is the incumbency circle here. Machine learning is a type of artificial intelligence and includes systems that can learn from data, identify patterns, and deep learning is a subset of machine learning. Deep learning is a type of machine learning methods based on learning data representations. And so AI is a very general term. I also want to point out that all of these, AI, machine learning, deep learning, have been in and continue to be in medical imaging, computer-aided detection, and computer-aided diagnosis systems. Let's think a little bit more on AI in medical imaging. It's been investigated for decades with focus on both human-engineered algorithms, most recently called radiomics, and deep learning methods. And these investigations include development of the AI algorithm, as well as evaluation of the end user when they are being aided by artificial intelligence. And this is important to assess translation to clinical practice. Now, AI can be applied at many stages along the medical imaging chain. So here's the imaging chain shown here, and I will go through one example here. So this is in chest radiography. AI might be developed to help distinguish between frontal and lateral chest radiographs to improve the hanging ability prior to interpretation. AI might be used for detecting an abnormality, such as here, looking for a pneumothorax. And AI might be used in the final visualization method. Most of my research is focused on AI in the quantitative image analysis, CAD, radiomics, in detection, diagnosis, prognosis, and therapeutic response. Most of my research is on AI on images that are clinically and routinely obtained in the population. Sometimes I do collaborate with others so that the development of a new image acquisition technique can be partnered with the image analysis simultaneously. However, most of the work is on images that are clinically and routinely obtained. And what we want to do is ask questions about the relationship between features seen in the medical image and the biology of disease so that eventually we can detect, diagnose disease early and give the right patient the right treatment at the right time. AI can also be used to improve the efficiency and workflow of medical image interpretation. If we think about what a medical image is, well, they are meaningless grayscale, color scale patterns unless viewed and analyzed by an intelligent observer. That could be a radiologist, a computer, or a combination of both of them. And what are the tasks of the human eye-brain system? Well, finding and locating a signal in the image, characterizing or diagnosing that signal as disease or non-disease, and then conducting some clinical decision-making on patient management through integrated diagnostics, monitoring the patient. Let's look at the task of AI through computer vision, radio, machine learning, deep learning. It's very similar. Here, we're converting images to quantitative values. Both of these, whether you're human or computer, you need to know the clinical task. Now, there's many clinical tasks. You can use AI to help in risk assessment, in screening, diagnosis, prognosis, treatment planning, assessing treatment response, patient management, and disease discovery. And we will go through some of these today. If we go back to that slide on what a medical image is, and we look at the terms computer-aided detection, that is finding a signal in an image, similar to the human task, or computer-aided diagnosis, classifying the signal as disease or not. So I think it's important to make sure you understand CADE and CADX. I put this slide in here because CAD and AI are commonly confused terms. I've heard people say, we're not doing CAD anymore, we're doing AI. However, now people are starting to reuse the term CAD, which is good. AI is the computer algorithm that exists within this whole system for various types of implementation in clinical practice. One such implementation is CAD, computer-aided diagnosis. It describes one of the ways how AI might be used in clinical practice. So it's very important to understand the images, the algorithm, and the medical question, but it's also important to understand how will that AI be used by the end user. Will it be a secondary or concurrent reader? Will it be a primary reader or a partial primary reader, such as in triage and rule out? Or will it be an autonomous AI system that replaces a human, which I don't think will happen. So it's important in AI research to look at and have your research encompass all aspects in order to expedite and enable the development and translation. You can't develop AI without knowing the medical question or even without knowing how it might be used. Let's think a little bit more about AI. And I always see it as three eras of AI in medical imaging. There's the pre-1980s, and there's the 1980s, 90s when CAD arose, and then the 2000s with the deep learning. What has changed? We have faster computers, larger data sets, more advanced algorithms, including deep learning. We have a realization of additional reasons and means to incorporate in clinical practice and more clinical questions that might be answered. However, we have the same basic clinical task of risk assessment, detection, diagnosis, therapy response, assessment. We have the same concern for garbage in, garbage out. We have the same potential for misuse or off-label use. We have the same methods for statistical evaluation, and we have the same need for a sufficient number of cases to span the distributions of disease and the distribution of normal presentations. And of course, the same need for multidisciplinary teams. So I want to walk you through this using two use cases, breast cancer and COVID-19. I will start with breast cancer. This is the 1994 prototype system for computer-aided detection. This is the first one ever. It was in our clinical area placed. It included the detection of mass lesions and clustered microcalcifications. This was placed in 1994. We had to digitize film. The results came up on thermal print. And here you have an arrow pointing to a true positive. There we have a false positive, and here we have a false negative. So the displays were very simple. The computers were very big. However, it did lead to the translation to clinical use. The first one was approved in 1998. It used very simple marks. Now there's a lot more information on diagnosis included in these systems. But let's think about this. In a study done in 2006, it was deemed that there was roughly 92% of screening facilities, hospitals, using CADE in their workup. So it had reached stable usage. However, a few thoughts. First, the system that received FDA approval back in 1998 included deep learning with a convolutional neural network. And we believe this is the first publication of a medical imaging use of a convolutional neural network. It wasn't called CNN, it was called the shift invariant neural network. Through the evaluation for FDA, the method was comparing the computer performance on priors. Those are missed lesions. Now that has changed to more of a reader study. But what it did demonstrate was that patients were ready for AI. AI was being used in clinical practice. Radiology patients wanted the AI to be used if it existed. However, we now realize that performance needed to be improved, needed to reduce some of the false positive rates. But we also learned, and we realized that radiologists needed to learn that AI systems should only be used for the task for which they were developed and approved. Not as a primary reader, if approved as a secondary reader, and this is very important. Back then, CAD was approved as a secondary reader. However, we hear stories of it being used as a primary reader. It should not be used off-label, and it should be used for other type of breast images. So a lot of progress was made. Now, computer-aided detection continues in breast cancer screening. Usually it is changed from a second reader to a concurrent reader, where the radiologist is reading the image while there's also an output from the computer. But it also has a role in improving efficiency, since many of the screening methods now are three-dimensional. 3D ultrasound, there's tomosynthesis, and there's breast MRI. Ultimately, the key evaluation is evaluating radiologists without the aid versus radiologists with the aid, and ultimately evaluating it in clinical trials or practice. I go through a few examples here. Here's AI in automatic whole breast ultrasound. This was on the QView medical system, which is FDA approved. This showed reduction in ABUS exam interpretation time while maintaining diagnostic accuracy. So here, the move was to use CADE to improve efficiency of the read. Here's a concurrent read AI. This is in the ICAD, FDA cleared. It showed improved accuracy and efficiency. These are more and more images are being presented here in 3D to the end user. And here's an example of computer-aided detection in breast cancer screening. This showed a change from a second reader to a partial independent reader. And this was used in triaging or rule out. So in this study, images went through a deep learning model, and in the simulation, they assumed 20% were deemed to be normal by the computer, and that those would not need to be read by radiologists. And in doing so, they found it showed an improvement in efficiency. There were less images to read, and also improvement in specificity without harming sensitivity. I want you to be aware of the two terms here. Triage is where you use the computer to order cases to be read based on some AI. Well, you order your cases to be read based on some AI-based priority setting system. So the AI system will order the cases, giving the most urgent ones top priority, still being read by the human. Rule out is when you identify cases that do not need radiologist review. And the study I just went through is similar to that, where you rule out these 20 don't need to be read. In computer-aided diagnosis, there are also more modalities used in breast cancer assessment. Full-field digital tomosynthesis, ultrasound, and MRI. And here what we're doing is using the computer to help characterize the abnormality and to indicate potentially a computer-determined probability of malignancy on a found lesion. The final decision on patient management would still be made by the radiologist. For example, here on this mammogram, this is a benign lesion on the left, a malignant one on the right. The middle one's more confusing, that in fact is a cancer. So here it's not detecting, but characterizing the lesion. There's, well, as in computer-aided detection, there's many papers in the literature on computer-aided diagnosis. And here I'm showing one can use human-engineered AI. This is your typical radiomics approach, as well as deep learning. And I'll go through two examples of those. Here we have our human-engineered AI for breast cancer on dynamic contrast enhanced MRI. You can think of this as a virtual biopsy. So after we automatically segment the lesion using fuzzy C-means clustering, we automatically extract various lesion features. These are the mathematical descriptors, the radiomics. And I should point out, radiomics is maybe less than 10 years, maybe less than 7 years old, though people have been extracting these mathematical descriptors for decades. So I just say that. So when you're doing a literature search, you make sure that you go beyond the word radiomics. These 3D and 4D features are merged by a classifier to yield signature. Now, if you train it between malignant and benign lesions, you would get an estimate of the likelihood of malignancy. If you train it with, say, different molecular subtypes of lesions, you would get a likelihood of aggressiveness. So how you train these features in the classifier will lead to what your output means. For this example shown here, these are the various radiomics features extracted. And we call this a virtual biopsy because it's automatic segmentation analysis. It's 3D, it's non-invasive, it covers a complete tumor, and it's repeatable. Here's an example of one of those features. Now, tumors will have increased blood vessels and different microvascular density and vessel permeability. We're looking at some of those aspects through contrast enhanced MRI. This is done in 4D for ease of showing. This is just a slice through the breast shown here. This is the computer extracted tumor, and it's done. What we're analyzing is we're looking at all those voxels. This is the uptake curve, where up here on the right, there are different types of uptakes. This is the time interval, and this is the MR enhancement. Here, these are the points where the image is obtained at different points during uptake. And many cancers, though not all, will show a rapid uptake and washout, where more benign tumors will have a very persistent or plateau type uptake. So what we did was we looked at all those voxels within the tumor. And you can see that some of them have more of a rapid uptake and some were quite slow in uptake. And we did two things. First, we looked at the characteristics of only the most enhancing, and we pulled out a most enhancing curve for kinetic evaluation. But we also looked at the texture. So if you look at the lesion, and red here, these are the cuts through the tumor. Red are the most enhancing voxels. Then we go down to the lower enhancing voxels. And if you look at that heterogeneity through texture analysis, you're basically looking at the heterogeneity of the contrast uptake, which you'll see later we related to the angiogenesis. Some people call these different things, regions, habitats, but this can all be done automatically in 4D. The other big area that we use in breast cancer is through deep learning, and often it's transfer deep learning. While there are many medical images out there, not many have been curated carefully with confirmed truth. So compared to the real world of images of cats and dogs, where there's millions and millions of images, it's often useful to use transfer learning, whether you do it through fine tuning or through feature extraction, the latter of which is shown here. The advantage here is no lesion segmentation is required, and also no extraction of segmented based features such as size, shape, margin, kinetics are needed. We've done this with feature extraction, where we use a pre-trained network and we pull out these features at the various levels, do various dimension reduction techniques, pass them through a classifier to yield a likelihood of malignancy. We always try to understand why something works or why it does not work. So here we had a database, probably around 900 or so. These images are confirmed by biopsy. So they're outlined in red if they're cancer and outlined in green if they're benign. So each dot here is a case. And this is giving you the computer output using human engineered features, radiomics, where this is the likelihood of malignancy ranging from 0 to 1. And this is using deep learning, transfer learning, going from 0 to 1. In a perfect world, all the greens would be here and all the reds would be up here, but there is a distribution of the computer output here. One thing to note is here is a benign case that the human engineered got wrong, while the CNN deep learning correctly claimed that it would be benign. Likewise, here's a green one right here, which the radiomic method, actually this was called wrong by got those two called wrong by one and not by the other. But what I want to point out is sometimes the human engineered way does better than the deep learning way, and also the vice versa. And that's important. And when you think about the human engineered, you can get away with less number of cases, less number of features, but it's not really trained on the less number of cases because it's based on what radiologists have used during their interpretations for many years. And that is based on years of training. So in a way, you have an indirect large data set influencing it. So I still highly recommend that both methods be looked at. We do this for digital mammography, ultrasound, and DCE MRI. And what we found is these are area under the ROC curves and the task of distinguishing between cancers and non-cancers. They both did quite well. And when we merged the output, we did statistically better. Going back to breast MRI here, I noted that earlier that it's important to understand how does the radiologist perform when using the aid. And this is a study back from 2011, where here we're looking at the performance of 6 radiologists reading the breast MRI on their own. And this is when they used the computer-aided diagnostic method that we had developed for breast MRI. And this was a statistically significant improvement. What I also put here is the computer on its own. I'm not suggesting that we use the computer on its own, but just pointing out it varies in areas of sensitivity and specificity different than the human. But what's important is that the human improved. This led to commercialization of this in the sense that this system, which included this most enhancing kinetic curve that I mentioned earlier, as well as a computer output that indicated where an unknown case set, this arrow, is calculated from this unknown case, where we've also calculated information on the size. This histogram is showing the distribution of cases in our training set for which we have the truth. And this is saying that this case probably is malignant. This then was translated and became the first FDA cleared machine learning driven system to aid in cancer diagnosis. I put this up here because the means of evaluation are very useful. This is a plot of showing the performance of the radiologist in the first read, that is without the aid. And this is with the second read with the aid. And you can see that all radiologists improved. But how do we improve the AI algorithm now? You've heard, well, use more cases, obtain better representation of the distribution of cases, conduct augmentation. So I'm not going to go through those are out there. But let's look at effective inputs and multiple input types. So this is from our DCE breast MRI data set. On here on the left, we have 2D information. This is from the central slice of the second post-contrast MRI. This one here is the central slice of the second post-contrast subtraction MRI. So this has 2D information and temporal information. And this is the maximum intensity projection of the image. MIP has 2D information, it's temporal information, and in a sense, volume information. And in talking with some breast radiologists, this is one of the starting points they like to look at to first see the lesion. So what we did was input these different types of images to the deep learning network to see how it would do. And here the deep learning network actually did better, as we expected, just like the human preference of it. I also want to point out something in this too. Here we're looking at what form of image do you pass to the deep learning network? And I always tell folks in developing deep learning to think like a human. When thinking about it, if you have infinite number of cases, you could just give them all the images and the deep network would probably figure it out. However, we don't have infinite number of images. So let's use the knowledge that we obtained from radiologists in their human interpretation of these images to decide what do we input to the deep learning algorithm. And I just showed you here that the MIP image did better. But I also want to point out that what we input is not the entire image, even though the radiologist looks at the entire image. What they're really doing is she's zoning in on this tumor here. So why not give the same to the computer? So what we input to the computer are these regions of interest in 4D. Okay. Think like a human and help the deep learning learn by giving it better outputs. We looked at multi-parametric MR imaging to see how we might incorporate that into the AI. So this is the human engineered radiomic method that I talked about earlier. We had DCE, T2 weighted, and DWI breast images, and we segmented the lesion. We extracted the various radiomic features, and these features are ones that can be automatically calculated from the computer. And then we looked at different ways to merge the multi-imaging information. We looked at feature fusion, where we merged all the features into one classifier to see the performance. And we also did classifier fusion, where each classifier was trained separately based on the type of image and the features. And then we merged the output of those. We also looked at doing the multi-imaging fusion using deep learning. And here with deep learning, we did this with DCE and T2 weighted. We could go through and train each of them separately and take the deep learning extracted features out and merge those, so we can merge the features. We could go all the way to the classifier, merge the output to the classifier. So here we're merging features, we're merging classifier output, or we actually can do fusion of the image. Keep in mind, if you're going to fuse the image, that they have to be registered. And when you fuse the image, you can again do transfer learning with feature extraction and look at those. And so we looked at those, and overall, as with the radiomics approach, you do better when you merge multiple multi-parametric MRI images, although the DCE component is the largest gain. Okay. Now, what is this virtual biopsy? So let's think about this. So this is what happens in breast cancer screening. If something is found, the patient goes through diagnostic imaging. If there's cancer, there's treatment planning, following up for response, and then there's assessment risk of recurrence. It's at this stage where often a biopsy is conducted. And with that, you can obtain the truth on whether it's cancer or not, or cancer subtype even. So you can think of this part here, this relationship here, as a discovery, understanding the relationship between the imaging and the histopathology, the genomics and all. Now, let's say you find a signature in that image, a group of features that really corresponds to cancer. You could take that and then translate it to other steps here. You could do predictive modeling of these image-based signature, but now in other tasks. And we call these virtual digital biopsies. And I should point out that we want to use virtual biopsy when an actual biopsy is not practical. You will not be biopsying all screening patients or in assessing the risk of reoccurrence, but could we use this knowledge from the discovery time in those? I just want to make sure I'm doing okay on time, right? Wow. We've done this with the most enhancing tumor volume, which was a very simple radiomic one, but basically pulls out automatically characteristics of the tumor to differentiate between which ones would reoccur and which ones would not. We've also used these radiomic features such as tumor shape, size, and heterogeneity, and looked at their relationship to cancer pathways through the TCGA, TCIA group. And what we found was transcriptional activities of various genetic pathways were positively associated with tumor size, blurb, tumor margin, irregular tumor shape, and that microRNA expressions were associated with the tumor radiomic phenotypes of size and enhancement texture, suggesting that microRNAs may mediate the growth of tumor and the heterogeneity of angiogenesis in tumor. Note, in doing this, we worked with a breast cancer oncologist and surgeon. We wanted to make sure that the findings that we obtained made sense. And that's crucial that this work is done in a multidisciplinary team. So now let's move to COVID. The COVID pandemic presented an urgent and critical public health crisis, and we wanted to address various needs: surveillance, differential diagnosis, prognosis, assessing response, and monitoring the post-COVID patient. Here, there was a role for imaging and AI. We started with chest radiography and CT. We are moving towards cardiac, brain, and other images. Just a few examples of their presentations are shown here. And we moved to develop various machine learning methods. We looked at the COVID positive negative, but more clinically is prognosis, using imaging to help assess the patient, monitor the patient. To do this, to develop AI, you needed surrogate markers of severity. You know, in detection, it's there or it's not there, but in severity, how do you come up with a truth of whether or not the patient is severe? So we had two cases, and I'll go through them. They both use different surrogate methods for assessing prognosis. In this first one, Isabel, who's recently graduated from the program, developed an AI method to perform prognosis for COVID-19, predicting patients' need for intensive care. That was the surrogate marker, where it's defined as either having been intubated or being put into the ICU. She looked at, these were all COVID positive patients from standard or portable chest x-rays. Again, those are not that many cases. So she used a curriculum learning approach where she first used the data from ImageNet. Those are everyday images, fine-tuned it with images from the chest X-ray 14 from NIH of chest images, cases from the RSNA pneumonia challenge, and then finally training with cases from the University of Chicago, making sure that she had an independent test set. And the goal here was, can you predict those that would need intensive care? And could you come up with maybe a visualization approach? And here's an example of an original, and here's one who needed intensive care, and this is one that did not. This is a difficult task. She found a AUC of 0.77, predicting the need for intensive care, which is quite promising. And now this is being looked at with triple the size of a data set. This is from Jordan Furman, another graduate student in my lab. Here, the surrogate marker was whether or not the patient was put on steroid treatment. And these are done on CT using transfer learning, another curriculum approach. He used the pre-trained network across the various slices and then merged those to give either a management recommendation or a monitoring output. So here on the left, we chose the pre-treatment. This is in the ability of the AI to predict who has severe COVID based on the surrogate truth of whether or not they were put on steroids. He then applied this across patients as they were in the hospital. Blue are the ones who did not receive steroids. So this is the prediction score. And the red are those who were receiving steroids at their various times in the hospital. And you can see by the time they were released, they were quite similar. This is very promising. And this was done on a limited data set of about 40 or 50 patients, which has now, we have 900 patients. So stay tuned for that. All this research led to MIDRIC. And you can learn more about the Medical Imaging and Data Resource Center at midrc.org. This was actually a brainchild of NIBIB. They saw that going to the major imaging societies in the US and having them work together could lead to this resource. So it's funded by the NIBIB. It is hosted at the University of Chicago. I'm the contract PI there. It is led by the APM, the ACR, and the RSNA. And it was established August 2020. So we're about a year and a half old now. And the goal was to address the COVID pandemic through imaging and AI. There are two major scientific components. One is to create an open data repository, an open data commons. And we do this throughout various technology projects, but also jumpstart AI in COVID. And this is done through collaborative research projects. To date, we have over 24 institutions involved, including academia, community practices, and the FDA, and over 100 investigators. You can see all of them at our website. And the goal here is to have highly curated and diverse data, enabling researchers to address topics no single archive could achieve independently. So we collect images, clinical, and demographic data. This is being developed, and you can see here the different societies are taking leadership roles. However, we all work together. And this is done through various data science committees. We do have a fourth one, but since the talk had to be given earlier, so it can get the SAM's credit, I couldn't add the fourth one. It just now exists, which is on the user portal. We spend a lot of time on this. This is, I believe, the future of medical imaging data commons. We take time to figure out what kind of standards are needed and what are the data elements. We take time to say, what are the policies as a contributor, as a user? We take time to figure out how to do the data quality assessment and how do we map to common elements, as well as what are the aspects of the end user portal. So here we have two input portals, one through RSNA and one through ACR. Then it passes through and with the APM's expertise in assessing image quality and rigorous methods of evaluation, we have helped determine methods for de-identification, curation, quality assessment, harmonization, and annotation. We have one output portal. It's on the Gen 3 Data Commons. So that's at data.midrick.org, and that's for searching, building cohorts, and downloading data. At that portal, we have the public commons, which is an open access. It's AI ready, trustworthy, fair, representative, and that's about 80% of the data we bring in. But we also have a sequestered data that has no access, and I'll talk about this later. And this is to expedite translation of AI through regulatory and clinical care. How does this work? So here's an example from RSNA and in Flanders. The medical imaging comes in through their site. They work with the ACR and RSNA, work with the donating site to obtain de-identified data. The data is curated and reviewed. This one is showing within the RSNA. And then it's passed from the RSNA to a bucket in Gen 3 for further data quality assessment. This slide here from Paul Kinningham shows the data quality and harmonization process. So as the information is going through RSNA and ACR, there is a point where one needs to make sure it's of sufficient quality, and does it have the correct DICOM header? Does it have the correct demographics? And to aid in cohort building, what will be the mapping? And currently, we're looking at and developing a mapping based on the LOINC mapping. This shows, and you can go to our update. This is old, but let me show you. We keep track of how many imaging studies we've ingested, and these are mainly radiographs and CTs. How many are currently undergoing quality checks and harmonization, and how many then are released on the open website? So roughly, some of these two equal this. The slide is old because, as I mentioned, I had to get it in for the SAM's credit approval. This now is not 15,000, but 29,000. That bias and diversity are very important to us. This is an assessment from May of 2021, where we looked at the MIDRIC data and the US Census data, just as an example of keeping track of what is coming into the MIDRIC and should we do diversity-directed collections. Currently, we have contributions coming in from 23 states. Some of them are at the contributor agreement discussion. Some of them are at prepping the data. Some are transferring the data. Some of them have their data undergoing quality checks and then double checked at Gen 3 and being out and put on the put portal. So if you're not one of those institutions from these 23 states, I invite you to join. I had mentioned the sequestered commons. And what that is as data is going through checks here, we pull off about 20% to sequester common. This will not have any access. What we will use this for, if an investigator or potentially a company want their system evaluated in an independent way, saying, this is my medical claim, this is my medical question, this is my population that I'm going to base my claim, can you test it? We will then extract from this sequestered commons using a task-based distribution method, sufficient number of cases to test the algorithm and go back to the investigator or company saying you have an 83%. We will not tell them how it does on any type of cases. And if they were to come back in a year, we would redraw based on that distribution from the sequestered data set again and give them a performance number. This is to maintain the integrity of the test set. And as I mentioned earlier, FDA members are involved in the development of many aspects of MDRIC, including the sequestered data set, so that we can accelerate translation of algorithms and give real world performance. I invite you to go to our websites to learn more about us, midric.org, to many aspects you can learn about us, as well as go to data.midric, where you can go into the exploration button and search, build cohorts, and download data and associated metadata. For more information, you can join our newsletter just at the website. We have monthly seminars. We just had one this past Tuesday, and we give updates on the diversity of our data. I mentioned that we also have collaborative research projects. These were determined from RSNA, ACR, and APM. And with this, we have multiple scientific work groups, the Grand Challenge Work Group, which is used to create and coordinate efforts on all aspects of challenges, and then look to potentially merge them to get a top performing one. And we have a bias and diversity work group with the goal of assessing and mitigating bias in data and machine learning, but we also keep track of the diversity of the MDRIC investigators. You want the diverse team working together here. We acquire partners and collaborators, both other government agencies as well as various societies working together. And currently we have 3 ongoing interoperability pilot studies. One, we want to relate the imaging data with the information in N3C, which has EHR data. Another, and we want to, in a sense, relate the data up in the cloud. Both have collected data, one imaging, one EHR. We also have one where we're working with NHLBI on their PEDO study. That data is hosted on Biodata Catalyst, and we want to, again, in the cloud, relate the imaging to the clinical and multi-omics data. And we also are working with Argonne. They have a pilot study, grant funded, that we're on to look at privacy preserving federated learning. I see in the future that the artificial intelligence will be done in partially centralized, such as MDRIC, but partially going through that centralized state to get to various federate other sites in a federated approach. So these are moving along quite well now. So what went wrong with AI during COVID? There's many articles out there. You can see here, hundreds of AI tools have been built to catch COVID. None of them helped. Common pitfalls and recommendations for using machine learning to detect and prognosticate for COVID using chest radiographs and CT. Well, a big part is the poor quality of data. There are many data lakes created. Some were even with JPEGs from images and published papers. And they became Frankenstein data sets. Sometimes the data lakes had duplicate cases. So in your training and testing, you might end up with the same patient, and that, not allowed. Duplicate data, poor quality, lack of external validation by the experts, which led to a lack of communication between AI developers and the biomedical experts, which gave shaky ground truth and incomplete understanding of how to do testing and the need for sequestered data. And of course, biases. Sometimes the data was collected for a specific clinical task, lacked specific populations, lack of diversity. And so we believe MDRIC is a solution to that. MDRIC now is mainly chest radiographs and thoracic CTs, but we're starting to collect images of the cardiovascular system and the neural system, as well as move our AI to monitor the post-COVID patient long haulers. And as I mentioned, we're collaborating with non-imaging COVID-19 data commons to integrate the multi-omics. And this, we believe, is a national resource. So this is what makes MIDRC unique. We want to support the medical imaging AI ML ecosystem. It is run by the various society, so we have strong representation of radiologists as well as strong representation for medical physicists. All are at the table. We want to put out high quality, representative, trustworthy data, addressing bias. We're a community. We're not just a data set. We're not just a repository. We're data commons with community, massive meetings weekly. We are sensitive to standards, sharing, transparency, and best practices. And because we're open, we want to lower the barrier of access so everyone out there can work on developing. We show here the various benefits. A big one is accelerating the translation. We just don't want it to be a database. We don't want it to be algorithms. We want to also translate. And with our sequestered data set, we're able to do real world quantification of algorithm performance. So I hope I have addressed these educational objectives. I know we started a little early, so I will end a little early. I want you to keep in mind these challenges of AI in medical decision-making. First, it's really important to understand what is the question. Is it detection, diagnosis, prognosis, response to therapy, or are you doing some non-supervised discovery? Is AI being used as an additive component in decision-making? Most likely. Or as a replacement? Not likely. It might be a replacement, such as in triaging, for a component. Is AI being used to improve performance or improve interpretation times? Is it for efficacy or efficiency? As long as you understand that as you're developing. And it's really important how the AI algorithm will be used in the clinical task as a second reader or concurrent reader, triage, rollout. Always remember garbage in, garbage out. Make sure you understand what kind of images, how you're doing your extraction that's going into your AI algorithm. And if you have an established AI system, understand what you're putting in to use it. Because once this gets out to the clinical, in fact, we had this. So if you have a system out there for breast imaging AI and someone puts in the wrong type of breast image and the computer doesn't work or it gives an odd result, you know what they say? System didn't work. It wasn't the wrong image was put in, it was system didn't work. So you have to consider the big picture in doing this work and make sure you have robust testing and appropriate data sets on which to do that. So I want to thank my lab. I have an outstanding lab with brilliant graduate students, outstanding research, senior researchers and lab staff, and of course, all those folks at MIDRC. So I end here and take questions.
Thank you very much, Dr. Geiger, for an excellent presentation. Julia, do we have any questions on chat?
There's one.
This response.
Should I read it?
Yes, please.
Okay. How do you find the truth in de novo breast cases where AI and human readers arrive at different conclusions? Biopsy. So we first obtain the truth through biopsy. This is, let's take it for the task of diagnosis. So it's cancer versus non-cancer. And we train the algorithm based on biopsy truth. And the result comes out as likelihood of biopsy. Now in your question, when it's being used clinically, we've done many reader studies, and some radiologists will say, you know, I'm good, I don't need this. We have other radiologists say, yes, I like this because it usually agrees with me, gives me more confidence. And then we have the other ones say, yes, this really helped. Now, when you think of, I always like to think like a human, in a human reading, you're going to have easy cases, clearly malignant, clearly benign, and those in the middle that are difficult. The same thing will happen with computers. And we've looked at repeatability where we bootstrap and we look at how confident the computer is. And the computer, like the human, is more confident at the clearly malignant, clearly benign, but not so much in the middle. So I've done reader studies both in-house in our labs, as well as assisting in FDA approvals. What I tell readers is if the computer's not sure, meaning it's giving like a 30% likelihood that it's cancer, meaning it's probably benign. If this was trained on a 50-50 prevalence data set, I go with your gut. Radiologists aren't always right. Computer's not always right. But in most cases, you should feel comfortable going with it. But they're going to disagree. After the fact, if the case goes to biopsy, you can obtain that information and hopefully it'd be a feedback loop for continuous learning. I don't know if that answers what you were looking for.
Thank you very much, Dr. Geiger. I was thinking about some other questions. Do you have a QA process for machine learning, and how you evaluate the prediction accuracy for a machine learning algorithm, especially regarding the presence or absence of a particular disease? Do you have any other comments? I know you almost answered to the question already.
Right. So we use ROC analysis a lot. So we have confirmed truth. It's a multidisciplinary team. So we're working with radiologists, oncologists. If it's a binary question, is it present or not? Is it cancer or not? We use ROC analysis. We use various bootstrap methods so that we're giving the performance level and the 95% confidence interval. We also, when we have a large enough data set, we'll look at repeatability of it. When we do comparison, we will compare the area under the ROC curve for the different methods. When we move to, well, I've done, and that's standalone evaluation. My algorithm performs this well on its own, but ultimately you have to say, how is it going to be used in the clinical arena? And that is being used because they always say AI will not replace the radiologist, but the radiologist with AI will replace the radiologist not using AI. So you see how it performs with radiologists. And again, we use ROC analysis, but now we're conducting ROC analysis, not on the computer output, but on the radiologist output. And we look at that, the radiologist interpreting the images without aid, and then we look at them using the AI in their interpretation and do the statistical analysis and comparing those.
Okay, thank you very much again. Let's see if we have any other question on the chat.
There is another question on the chat.
Oh, good question. When combining the multiple classifier output, what's the rationale using the soft voting instead of training a new classifier, taking the outputs from other classifiers? Good question. And simple answer. Basically, you know, if something simple works, use it because it's more efficient. So if at the end we have the 3 outputs from, say, 3 different classifiers, we could create another classifier to take those output. But to do independent testing, we have to go and make sure we have one big loop where we're training everything in that to test on the independent. Averaging is actually a very robust method when you have such numbers. And then if you say, I'm just going to average the value, there's no training. You don't have to worry about going back and training, you know how to average. So that's the reason we did that. As we get more in cases where we'd have to do that whole big training loop again, starting with feature extraction, merging the individual classifiers, merging the features in the individual classifiers, then merging the output of the classifiers, we can look at that. I don't think it will make that much of a difference. However, because in that one example, the DCE is such a strong contender for doing so well, it might. So good question. All these are good questions.
Okay, thank you again. You will receive shortly an invite to join a breakout room. Dr. Geiger will also join the breakout session to continue informally the discussion with attendees interested in the subject. The main session will continue in parallel. We'll have a break until 10:30 a.m. when we'll start the oral presentation for the young investigators. During the break, we'll display video for our sponsors.
Harmony is the most productive linac that we've ever made, balanced with the best in-room experience in radiation